Hello, my name is Sharon James. I'm an experienced primary healthcare nurse, but also a PhD candidate at the University of Wollongong, Australia, and due to submit my thesis in a couple of months' time. I've been doing that with the support of the Australian Government Research Training Program Scholarship, and my PhD is a mixed methods project exploring lifestyle risk communication between general practice nurses and patients in general practice. My other interests include communication, lifestyle risk prevention, chronic disease management, and nursing roles in primary healthcare. I would also like to acknowledge the support of my supervisors, Professor Liz Halcombe, Dr. Jane Desborough, and Dr. Susan McGuinness. Internationally, funding and government policy inadequacies are reflected in lifestyle risk factor increases. For example, rapid unplanned urbanisation and the globalisation of unhealthy lifestyles can foster conditions such as obesity. We know that chronic conditions include type 2 diabetes, hypertension, obesity, and some cancers are caused by lifestyle risk factors. Addressing lifestyle risk factors in Australia has the potential to prevent 31% of the disease burden. In general practice, 53.7% of the patient presentations have at least one lifestyle risk factor. Illness prevention, health promotion, and chronic disease management, or CDM, are core components of the general practice nurses, or GPN's, role. In the general practice setting, 67.2% of GPN patient encounters consist of disease-specific health education. As part of CDM, discussions about lifestyle risk reduction through smoking cessation, adequate nutrition, moderating alcohol intake, and enhancing physical activity are an important part of GPN patient consultations. Communication of lifestyle risk, including potentially emotional subjects such as weight management, require a person-centred approach. However, many factors influence the GPN role, such as workplace organisation, funding, as well as patient, personal and professional factors. On top of this, several studies identify that the GPN role is largely underutilised, particularly in terms of being supported to their work to their full scope of practice. Therefore, this project sought to answer the research questions: how do GPNs communicate lifestyle risk with patients, and what are the perceptions of GPNs in communicating lifestyle risk with patients? A convenient sample of 15 registered nurse GPNs and 40 patients were recruited from southeastern Australia between the late 2017 and early 2018. This is a concurrent mixed methods project and used a video observation and semi-structured interview method with GPNs. Audio of videos and interviews were anonymised and then transcribed verbatim by a professional transcription company. And patients were eligible to participate if they were adult, English speaking, presenting for a chronic disease management consultation, and able to provide informed consent. And CDM consultations were targeted due to the likelihood of lifestyle risk conversations being included. The quantitative phase used video observation to evaluate nonverbal communication. The Nonverbal Accommodation Analysis System, or the NAS, was used for analysis, and GPN computer eye contact time was also measured. The NAS was used to analyse rapport and strengthening of therapeutic relationships through convergent to divergent accommodation behaviours between the GPN and patient. And this means how we assimilate our behaviour and speech patterns with the patient. Due to suboptimal camera positioning or operator error, 4 consultations, which included 1 nurse, were excluded. Therefore, 36 patients and 14 GPNs were included in the video analysis. We also used a representative subset of videos, 1 from each nurse, to do some deductive content analysis of motivational interviewing, or MI, skills and techniques used. The exploring, guiding and choosing model was used for this analysis. The qualitative descriptive interview phase aimed to understand GPN experiences of lifestyle risk communication, and 15 semi-structured interviews were undertaken. Thematic analysis was informed by Braun and Clarke. So, participant characteristics. So, patients were mixed in terms of gender and had a mean age of almost 67 years, and most presented for a care plan review. And the main health issues relating to medical history were high blood pressure, diabetes, and arthritis. GPNs, there were 15 of them, and they were from 14 general practices. All were female with a mean age of 43.5 years. And participants had worked as a registered nurse for a mean of almost 16 years, and in general practice for almost 7.4 years. Consultations, well, there was over 17 hours of video recorded data used for nonverbal analysis, and the subset of consultations was used for content analysis, represented over 7 hours of data, and the mean duration was 28.7 minutes, and for interviews the mean duration was 24.3 minutes. So now we'll talk about the nonverbal communication. Nonverbal communication is a broad term consisting of those interactions with or without speech. In practice, we use nonverbal communication for expression and to show attentiveness and engagement. Nonverbal communication is important for the direct and indirect outcomes of care, such as patient disclosure, engagement, rapport, satisfaction, and enhanced function. And this may be done through facial cues, eye contact, touch, body, posture, and position. For example, a GPN who focuses on the computer screen throughout the consultation might seem disinterested, thereby influencing the GPN-patient interaction. And using the NAS tool means that the occurrence of each behaviour in the first 2 minutes and last 2 minutes of each consultation were calculated and compared to determine the direction of accommodation movement. That is, how the GPN and patient mirrored each other's behaviour across the 10 behaviours indicated. Convergence indicates an adoption of behavioural similarity to the other party, such as through language or body position, and indicates a person-centred approach. Divergent accommodation, however, shows behaviour moving away from the other party to accentuate difference, such as medical jargon. The distance or control created by neither party aligning or diverging behaviour with the other indicates behavioural maintenance. Most behaviours show joint convergence. And from the joint convergence of GP-patient interactions, nonverbal behaviours such as laughing, smiling, and eye contact were most often categorised. We also tested the significance of GP and computer eye contact time across the consultation. So from these results, overall GP and patient convergence is promising for therapeutic relationships reflective of rapport building. Effectively using convergent behaviours such as gesturing, which significantly increased over the course of consultations, can positively impact on information exchange, patient satisfaction, health improvement, trust in practitioner competence, and person-centred communication. Asymmetrical patient divergence of speech rate and significantly reduced patient eye contact across the consultation can be indicative of dominance. Joint divergence of talk time, interruptions, and simultaneous speech may indicate GPNs and patients maintaining their own social identity or reflective of some patterns of patient presentation such as depression or confusion. The GPN computer eye contact time results may be related to the prioritisation of other actions undertaken by the GPN during CDM consultations and between analysis time points. This includes activities such as blood pressure and weight measurement. Increased computer use, including while talking, can negatively impact on nonverbal behaviours. Strategies such as involving patients in viewing the computer screen are perceived positively by patients. The next study used in video transcripts was about GPN MI techniques, and MI is a person-centred behaviour change approach known to be effective in primary care. We used the Exploring, Guiding and Choosing model to analyse GPN skills and techniques needed during MI. Exploring includes assessment, building rapport and collective decision-making about lifestyle risk reduction priorities. Exploring techniques include the use of open-ended questions, listening, reflections, exploring ambivalence, and agenda setting. Guiding involves GPNs encouraging patients, assessing patient perceptions of risk importance and their confidence in achieving change, as well as open-ended questions to prompt patients to verbalise change talk. Choosing includes goal setting, action planning, barrier resolution and follow-up. Collaboratively establishing strategies to achieve risk reduction requires GPNs to work with patients to reduce tensions related to changing behaviour. Arranging ongoing support and evaluation forms part of the goal setting process. So exploring results, listening shown through content reflections assists information sharing and building rapport. We have a double-sided reflection such as, so it sounds like you enjoy drinking with your mates, but you don't like what happens after you start drinking. So that wasn't demonstrated in this study. And it helps explore ambivalence by rationalising reasons for and against changing behaviour. GPNs in this study often followed a non-collaborative question-response format potentially aligned to the CDM remuneration structure or the GPN's agenda. For guiding, GPNs need to leverage their relational continuity with patients. So while discussions depend on patient readiness, directive approaches such as guideline recommendations can be resisted by patients. Ascertaining readiness through using confidence and importance scales helps individuals to process and verbalise information. And following this, summarising patient priorities and choices demonstrates listening and clarifies understanding. For choosing, when lifestyle-related goal setting is limited, it may be due to competing clinical priorities, referrals, lack of GPN skills in goal setting, or patient readiness When GPNs used open-ended questions to explore patient strategies for meeting lifestyle goals, this facilitated commitment talk to make a behaviour change by the patient. So maintaining rapport during consultations allowed GPN scope to use communication strategies for understanding patients' risk factors and consider potential interventions. However, there were missed opportunities for further patient exploration, agenda setting, or education relating to lifestyle risk. Findings indicate GPNs in this study would benefit from addressing the ad hoc GPN professional development opportunities, time, and organisational support. So this represents the results from the interviews, looking at interactional elements and barriers and facilitators. So some participants reported using scare tactics, but others described being approachable and more patient-led in their dialogue. And strategies such as providing smaller amounts of information depended on the nurse's perception of patient capacity to listen to the GPN about lifestyle risk and undertake lifestyle risk reduction activities. The use of phrases like chipping and digging away featured in some participants' dialogue and showed a perceived need for ongoing discussions. For patient factors, motivation was perceived necessary for lifestyle risk reduction readiness, and few participants overtly discussed strategies for resolving barriers, preferring to wait until patients indicated willingness to do so, or rather, as one nurse said, trying to push it down their throat. Some participants reflected on experiences when the patients were unaware of the GPN's role, with some thinking the GPNs were the podiatrist or the dietitian. And the need for education about the referral process prior to consult was seen as one way to enhance patients' readiness for consultations. And so for barriers and facilitators, differences in participants' education type constrained their scope of practice and confidence in lifestyle risk communication. Participants also wanted accessible education for factors such as changes in the primary healthcare organisations, workplace priorities, time, location, remuneration, and as one has said, the costs involved of being away from family impacted on this. Workplace organisation, time and targeted billing arrangements were described as constraining the prioritisation of lifestyle risk communication. And as one nurse said, feeling as though you have to see as many patients as you possibly can was a barrier. Despite practices receiving government block funding initiatives for GPN services, most lifestyle risk discussions regarding GPN's time were related to billing and the need to involve the GP. However, some participants and practices showed initiative by regularly incorporating lifestyle risk discussions within consultations despite funding constraints. Rather than routinely discussing lifestyle risk with patients, the GPN's perceived relevance for this was influenced by the prioritisation of this compared with other clinical tasks. Participants also spoke about how patient factors such as the patient's life or medical stressors impacted on the perceived prioritisation of lifestyle risk reduction. And for facilitators, some participants perceived that opportunistic discussions, collaboration, resources, support and appropriate time allocation were beneficial for lifestyle risk communication. Some participants had worked to enhance their education, experience, confidence and accountability, developing more autonomous roles, and gaining insight into what patients' main concerns are informed GPN's prioritisation of referrals and navigation of their care needs. So to ensure optimal patient outcomes and clinical expertise, in this integral aspect of the GPN role, three key messages have emerged from the project findings. These are the need to leverage and develop GPN strategies and lifestyle risk communication, support the professional development of GPNs and lifestyle risk, and improve organisational support and funding for GPN patient discussions about lifestyle risk reduction. GPN strengths in convergent accommodation and content and relational communication skills for lifestyle risk communication should be maximised. And these strategies can be achieved through professional development, provided that ongoing and effective training meets the needs of GPNs. Current organisational support for autonomous roles in communicating lifestyle risk is inconsistent and reliant on practice-based priorities and funding. Enhancing GPN opportunities in communicating lifestyle risk are required to meet the increasing demand for CDM services to improve the health of our community. So here are some key references, publications to date, and my contact details should you want any more information about this research. And I'd like to thank the patients, practices and nurses for the participation, and thank you for listening. Thank you.